Queens West Oahu Virtual Speaking of Health Lecture Series. My name is Eric Barsatan, and I'm the Manager of Physician Relations and Medical Staff Services here at the Queens Medical Center, West Oahu. Today's Speaking of Health topic is palliative care. Right now, throughout the presentation, you could ask all our viewers to be on mute, and if you have any questions, please type your questions in the chat box, and our speaker will answer them at the end of our presentation. At this time, I'm honored and privileged to introduce our speaker, Louise Greencorn, Palliative Care APRN, here at the Queens Medical Center, West Oahu. Welcome, Louise. You may now proceed with your presentation.
Thank you. Thank you. So like they were mentioning, my name is Louise Greencorn. I am an APRN here at Queens West. I do a very special service here called Palliative Care. And I really wanted to talk to the community a little bit more about the value of palliative care and how it can actually assist you and your family in need. So let's go ahead and get started. So some of the learning points that I do want to talk about is just general overview of what palliative care is, the delivery of care, some of the effectiveness of how palliative care can help you and your family, and some really important resources that I think is going to be beneficial. I usually like to start conversation and do a little talk story, kind of Hawaii style, and talk about a patient that really resonated to me. When I was first starting off in this role, I had the privilege of being with the pain and palliative team at Queens Punch Bowl, which is our big mother company. And I had the opportunity to meet a patient that really resonated with me and really showed me that, you know, this role is so much more than you know, what people might think it may be. And she was a 46-year-old female. She came in with metastatic cervical cancer. So cervical cancer that had kind of moved to different parts of her body. It metastasized to her liver at the time. She was still receiving chemotherapy and radiation and was currently in readmission, but when she came in, they found out that it had progressively gotten worse. She was having severe flank pain and right upper quadrant pain in her belly, and also a lot of nausea. One of the big things that she had mentioned to me when we were talking is, you know, despite everything, one of her biggest goals was to fight for her grandson. So, you know, we had a big conversation about things. We were talking about some of our goals, some of the things that she really wanted out of her medical care. And really just get her symptoms under control. And so after speaking with her, you know, we were able to get her on a really good pain regimen. We started her on some medicines to help with her nausea, got her some really good supportive care outside of the hospital with one of the hospice and supportive care teams. And also got her involved with some of the chaplain services because she was a Christian by faith. So overall, once she left the hospital, she kind of bridged over and was able to receive the same type of services that she received in the hospital. And so she was able to continue with her chemotherapy and radiation. And, you know, the initiation of palliative care really did assist and help her with her overall, you know, diagnosis. Oh, sorry. So this is a really fun slide. We like to think of palliative care as the umbrella, not the rain. So I had read this in an article that was sent out to us, and there's two parts to it. If you see part A on the top, it says late palliative care referral versus part B, which is early. Late palliative care referral is, you know, you get diagnosed with a serious illness. A few months later, you're still kind of in the unknown. You don't really know what's happening. Eventually, you know, your care team will come and provide you the umbrella or some support in that. And, you know, overall, they kind of wish that they had a little bit more support during that time when they first got initiated with the diagnosis. But what we would really like is for early palliative care referrals to where when they get initially diagnosed with it, we provide them with the support or the umbrella, as you like to say. So when in time of need, months later, they're still considered dry and they're still doing everything that they need to do, and they have the support that they need instead of worrying about all the other things that come along with it. So general overview, there's a lot of confusion when people talk about palliative care. They sometimes mistaken it for hospice. And, you know, my biggest thing is I wanted to be able to incorporate some of that and be able to tell the difference between the two. But I want to talk a little bit more about what palliative care is, how it derived, and where it came from. But the World Health Organization, they estimate about 40 million people are in need of palliative care every year. And this is worldwide. 78% of them live in low to middle income countries, and only 14% of them actually receive them in the world. But overall, I'll show the statistics in the States as well. Usually, early delivery of palliative care reduces unnecessary hospital admissions, and most patients, the majority of adults that really do need palliative care, have chronic diseases such as cardiovascular disease, cancers, chronic respiratory diseases, and things like that. So, you know, the need for it is there. As our population gets older, it's going to become more apparent that the assistance and support that they need is going to be there, and palliative care could be a possible option for them. I just took this from the World Health Organization, but it's a really great definition. It's, you know, palliative care is an approach that improves quality of life for patients and their families that are associated with life-threatening illnesses. So when we're looking at a patient, we're not just looking at them as a patient, we're looking at them as a whole person. And we're looking at things like their physical, psychosocial, spiritual needs. So we're looking at them overall, so we can really help provide them the best quality of life. A little history on palliative care. I learned this a little bit, which was really interesting to me because I didn't really know where palliative, the actual word, came from. I had to kind of look this up myself. But it actually comes from a word pallium, which is a Latin word for cloak. And cloak, ideally back then, was to cover up. So the meaning really grew from the idea of alleviating or reducing suffering. And that's kind of what our big role is here. Palliative care did initially come from hospice care, and it's been kind of branched off into a bigger spectrum. It's kind of evolved from traditional hospice, where, you know, patients who are living with a serious illness can now get support that they need while they're going through this debilitating disease. This is the growth of palliative care in the US, which is really interesting to me. So if you look on the scale here between 2000 and 2020, there's been a pretty significant increase in palliative care programs in US hospitals. So in 2020, we're looking at about 24%. And then now, you know, pre-COVID, maybe even more now, there's about 83%. And so when looking things up, it's actually one of the fastest growing fields in healthcare right now. I took this from a palliative care summit that was done here. Some of the more interesting things for me in this slide, it's really busy, I'm really sorry, was more of, you know, we initiated a pain management program at Queens, at the Queens Medical Center downtown in Punchbowl. And then it also kind of talks about how it's kind of developed over the years. You know, I would say the majority of the hospitals here on island all provide palliative care or some sort of palliative care program. And now we have multiple hospice and palliative care programs outpatient that can assist patients as well. So the development of it in Hawaii has actually been quite done really well. So the outreach to getting patients into a palliative care program would be more, what's the word I'm trying to think? There's the development of it. You'll be able to get access to it. I particularly like this slide just because it really does compare palliative and hospice services. When we look on the palliative services side, it talks about, you know, it really can be done at any stage of the disease. It's usually paid by self-insurances. So in Hawaii, it would be like HMSA or UHA. You can still receive palliative services at the same time as your curative treatment. So chemotherapies, if you need to come to the hospital to get certain treatments, all of that is still provided for in a palliative service spectrum. When we're looking on the opposite side, we're looking at hospice services. Those are usually paid by Medicare, Medicaid, those types of things. The prognosis of a patient, meaning the lifespan of a patient would be 6 months or less. It doesn't necessarily include curative treatment anymore, primarily because patients, their lifespan is kind of limited at this point, and maybe their focus is more on comfort care. But the things that they both have in common is that, both do provide comfort. They do provide stress relief. They are able to provide symptom relief. So pain, anxiety, nausea, shortness of breath, all of those are incorporated in both sides of services. And then, of course, the spiritual and psychosocial relief as well. I think the big takeaway from this is that palliative care is able to be delivered concurrently or together with cure or oriented and life-prolonging therapies. This is a palliative care model that it could be very beneficial. I think it shows something that's, we're trying to move into. On the very top, it talks about the old kind of model of how palliative care is, where a patient gets diagnosed with a disease and then they kind of wait a long while for their Medicare hospice benefit to take effect. But during that time of life prolonging care, they don't really get any support that they need there. And that kind of goes back to that cartoon thing that I showed in the beginning of the presentation, where they don't get that umbrella. And then we look at the new portion is, when they do get diagnosed with the illness, they get that umbrella, they're able to get the support that they need, the symptom management aspects of it. And then eventually when, their diagnosis gets a little bit more progressed, they can look more into hospice care. But at least at this point, they've had the opportunity to really have all the support that they need throughout the entire time that they've been diagnosed. So patients that benefit from palliative care, I probably mentioned it many times, but high-risk patients, patients with frequent hospitalizations, socially vulnerable, sometimes patients and families that are just exhausted, people with multiple comorbidities, they're frail, cognitive impairment. There's an array of different things that there's a possibility of palliative care being beneficial for patients. So when you really look at it, it's not just patients with cancer. It's multiple things. Patients who have advanced lung, heart, kidney disease, patients with AIDS, Alzheimer's disease and dementia, cystic fibrosis, multiple sclerosis, and things like ALS as well. So there's different aspects of things that we can look into when looking into palliative care. So the delivery of care. So I don't know if you read in the previous slides, before palliative care was probably provided in like small communities or in spiritual places. But now, depending on where it's initiated, palliative care is provided by a team of specialized healthcare professionals, all that are very much trained in the field. So we're looking at physicians or specialists, nurse practitioners or advanced practice nurses, registered nurses, pharmacists, social workers that can help with all the social aspects of things, dietitians and nutritionists if patients are having difficulty with feedings, religious or spiritual advisors if they're spiritual or religious at all. And they work together to work on physical, psychological, social, and all aspects of the patient's overall picture. Where it's delivered. So there's several places that palliative care can be delivered. One is hospital-based. So the type of palliative care that I provide is a consultation service within the hospital. There are some hospitals that do have dedicated palliative care units. We also have nursing facilities such as long-term care or short-term care facilities, and then in the community. So we could do it in an office-based thing where the patients go and see a palliative care provider and they'd be able to provide assistance there, or it can be at home, or even telehealth, which is kind of a new thing as COVID has been emerging and continuing to. But most of the time, I would say that what I've seen is palliative care is either done in the hospital or at home, but there is so many different aspects and ways that it can be delivered. How it's paid for. Most of the time, palliative care is paid for by government or private insurances. So if we're looking for HMSA or UHA, those have been some of the things that I have seen. But then there are other aspects of it. If there might be some opportunities to look into for patients who don't have those. And it's always good to check because there might be opportunity for palliative care options based on the insurance coverage that they have. The effectiveness of palliative care. So, overall, the relief from pain and suffering is going to be probably the biggest and most significant thing. It really enhances quality of life. It offers the support system to help with patients and families cope with their serious illness, a team approach to address the needs. So, a lot of the time, there's some, and enhances communication. So when we're talking with patients, there's sometimes a barrier or miscommunication between providers, and sometimes that palliative care specialist can help kind of put all the puzzle pieces together and enhance that communication so the patient knows what's going on and is able to continue providing quality care for them. And there's a possibility of even lowering costs and possibly extending life. That's, it really just depends on the scenario and each individual patient. I like to put this on here. This is more for providers, but it does show that for us, we do have domains in palliative care, and it kind of talks about the aspects of care that we do look at, and it really does show everything that embodies what we do in the kind of care that we provide for patients. So we're looking at everything: physical, psychological, spiritual, cultural, everything, and even legal and ethical things that we look into. So a lot that goes into the role, but really trying to incorporate all of those things in helping the patient. Issues addressed in palliative care. So real quick, physical symptoms, emotional coping, social and spiritual cultural things. I'm going to go a little bit into it more in the next couple of slides. So the first part is physical aspects of care. So physical symptoms. So I gave an example of my young female patient with cervical cancer. She was having really severe abdominal pain. So, being able to provide her with pain management, that was extremely helpful. We gave her some anxiety medication to help with her nausea and her anxiety at the same time, and shortness of breath and constipation. So we're looking at all these things, but we're also looking at things that are not necessarily medicine. So we're also looking for nutritional therapy, physical therapy, and deep breathing exercises, other things that are not necessarily always incorporated with medicine. Emotional and coping, depression, anxiety, of course, that's going to be a huge thing in palliative care. So addressing some of those things and maybe providing them referrals to professionals that can help and assist with that. Social needs, some of the big things is, you get diagnosed with a serious illness and you're worried about your legal and financial worries. So guiding patients in that aspect is also something that we can assist with. And then, of course, the spiritual and cultural part. So there are some patients that are very spiritual and cultural and want to be able to incorporate that in their medical care. So having referrals to religious leaders or chaplains, those are all very important. Real quick on some resources. Kokoa Mau is probably one of the best resources that we have here in Hawaii. It's under kokoamau.org. It's a movement to improve care of those with serious illness and loved ones. So it really does provide additional service or information about advanced healthcare directives and post palliative care information, hospice care information, and it's all there on the website. It's all wonderful. They come in different languages as well. So the opportunity to learn more about some of these services that can be available is there. I just want to briefly talk about these. An advanced healthcare directive looks kind of like that. Kind of the big pointer, and one of the things that actually really do appreciate about this directive is it does have the power of attorney aspect of it so that patient can actually designate an agent to make medical decisions for them. Everybody over the age of 18 should consider maybe having an advanced healthcare directive. Kokua Mau does provide it in different languages, some of them that are very spoken of here in Hawaii. So like Chinese, Tagalog, Ilocano, Japanese, all those languages is all incorporated in the website. Pulse, I don't know if anybody's seen these, but not everybody needs a pulse, but these sometimes are filled out and it's transferable and a portable medical order that helps kind of facilitate what the patient would want in this, if they would want CPR, if they want things like breathing machines or not, whether they would want artificial nutrition through a feeding tube. All of those things are discussed, and between you and your provider, you can have that conversation and decide on those things. These are some of the resources that we have that I technically use quite often. Kokua Mau being on the top of there. There's also an advanced palliative care website that you can also go to. We call it CAPC, and some other things as well. And then I had a video, but I think it might be a little difficult to show because I'm not very good at electronics. I'm so sorry. But any questions? I'm gonna let Eric kind of assist with some of that. I think in order to ask questions, you can write it down.
Actually, this is Eric. I'm back. Sorry, I was having technical difficulty there. Unmuting me. Yes, now, again, thank you so much, Louise, for that great presentation. So now let's go ahead and proceed with the Q&A portion. Let's see in the chat box if anybody has any questions. I don't see any there, but there was one question came up while you were presenting. That question was regarding costs. They know that insurance does cover the cost, but what about if you're private pay? What kind of costs are we looking at?
It really depends. Sometimes with some insurances, it'll pay partial. But the best thing to do is actually reach out to your palliative care team and our social work team, and they can really assist with those questions and really trying to figure it out. It's really difficult to say the actual cost on it, but ideally, some of the resources that we have, the palliative care programs outpatient can really assist to see if there's any additional cost or if there's anything that can be additionally used for that too.
Okay. Actually, I just have another question that came up, and this is regarding about friends, support from family and friends. How do they normally incorporate family and friends in the palliative care?
Oh, good question. A lot of the time when we have these long discussions with the patient, we really try to incorporate the family and friends in these conversations so they can hear what the patient really wants and what their needs are. So having family discussions and group discussions are very common. And we really highly encourage that just so that everybody is on the same page. And yeah, ideally that's kind of how we roll with that. And for myself, I usually have conversations with the family on a regular basis. So I'm talking to them quite frequently just to update them on the patient's status and, whatever is going on with them.
Another question that came up is regarding, when you need the care, do you need to have your primary care provider refer you to palliative care, or you can just reach out to a palliative care team?
Well, the way that my services work is I actually, I'm an inpatient hospital consult service. So for me, it would be the attending doctor in the hospital to consult me. But in an outpatient setting, they can actually reach out to some of the there's palliative and hospice care services that they can reach out to and go into and look into it on their own. And I believe Kokua Mau has some information on how to get a hold of some of those resources. But There's also opportunity if they wanted to talk to their primary care physician. They also have resources that would be able to guide them in the right direction.
Excellent, very good. And we have a question from the chat box from Lisa. And the question states, my cousin has COPD and he needs social and meal support, as well as palliative care for breathing issues. He is housebound and not necessarily open to have someone in his home. What kind of care can I get for him?
Oh, let's see. Let me try. Can you repeat that question? I'm trying to think of the whole scenario.
It says, my cousin has a COPD and he needs social and meal support, as well as palliative care for breathing issues. He is housebound and not necessarily open to have someone in his home. What kind of care can I get for him?
Oh, that's a good question. So a lot of the time there's different resources that he can get. The family can actually reach out to the palliative and hospice teams just to see if there's any other additional support they can get. Maybe speaking to a social worker can help provide, like Meals on Wheels or something where there's meal support and things like that. With palliative care, it doesn't necessarily mean they have to have somebody coming in regularly, but the good part about it is that there's the support that they need when they do need that. So it's really based on what the family's needs are. So they don't necessarily need to get palliative care coming in often. But the opportunity for the support would be there, and that might be the most beneficial thing for that, for her cousin.
I see. Okay, hopefully, Lisa, that answered your questions. All right. I don't see any more questions, but if you have any question, please put them in. Actually, there's...
This is Renee. Can I interrupt? Can
Sure.
you go back? There was a request here to go back to the resources page,
Oh, of course.
just so that they can take a look at that. And were you able to answer the question from Papa Ola Lokahi? Oh, no, not that one. About the doctor's prescription to get palliative care. Did you answer that one already?
Oh, no, I did not. And no, you don't necessarily need a doctor's prescription per se. You could just need a referral and the right people to call. In an outpatient setting, ideally, you can reach out to some of the hospice teams, which actually provides palliative care as well, or supportive care. Both would be able to provide and assist with getting you the resources that you need. And if you actually go on Kokoa Mau website, I believe there's opportunity and they give you numbers as well.
Okay, very good. Yeah. All right, any more questions?
There was another one that just came in. If you want to read that one, Eric.
Yes, from Papa Olalokahi. In some states, palliative care is covered by Medicaid. Any idea on whether palliative care will be covered in the state of Hawaii in the near future, and what needs to be done to get this covered by Medicaid?
Very good. That's a good question. I do know, and I'm not 100% sure on this, but I do know that the state is really trying to work on getting more opportunity for other patients that need palliative care and the opportunity to be there. I know that there's a team of palliative care specialists that are really working on that. I don't know where they are in terms of getting the accessibility to patients, but I do know that the state of Hawaii is working on that. So I'm hoping soon, because then that way we would be able to reach out to more people.
Okay. All right. Yeah. Yeah, I think that's all the questions that we have. Again, thank you so much, Louise, for the great presentation. And so thank you very much. And also like to thank all of our virtual audience for joining us today. So that concludes the Speaking of Health presentation for September. At this time, we'd like to ask all of you, our virtual audience, to please complete the evaluation information, which is on your screen. Click the URL in the chat box or simply scan the QR code on your screen using your smartphone to complete the evaluation. It is a brief evaluation, so we'd like to give you a few moments. And as always, we'd love to hear your feedback and comments. And please make sure you don't log out after you completed your evaluation. Yeah, I think a lot of people are done. So again, the Queen's West Oahu Virtual Speaking of Health Lecture Series is the third Thursday of each month at 12 noon to 1 p.m. Please join us for the next lecture, which is scheduled for Thursday, October 20th, and our speaker will be Dr. Ashley Maramuto, breast surgical oncologist here at the Queens Medical Center, West Oahu, who'll be talking about diseases related to women's breasts. It's another excellent topic. Look out for the announcement, which will include the registration information. We hope to see you then, and feel free to share or forward information to your friends, family, colleagues, and anyone you think may be interested. On behalf of our COO and Senior Vice President, Darlene Chadwick, our Chief Medical Officer, Dr. Ronald Kuroda, and the entire Queens Medical Center West Oahu, mahalo nui lua. Thank you very much for joining us today. Until next time, please take care and always be safe. Aloha.